Let's start. Hello everyone, and thank you all for joining us today for Psychiatry Grand Rounds. For those of you who don't know me, my name is Nick Hovda, and I am the Administrative and Scheduling Chief Resident of the University of Washington Boise Psychiatry Residency Program. And it is my privilege and honor to introduce today's Grand Round speaker, Dr. Anna Ratzliff. Dr. Ratzliff obtained her bachelor's degree with a major in biology from Stanford University before obtaining her MD and PhD from the University of California, Irvine. After graduate in medical school, Dr. Ratzliff completed her psychiatry residency at the University of Washington in 2009. Throughout her career, Dr. Ratzliff has been the principal investigator for numerous studies with research grant totals received of over $7 million combined. Much of Dr. Ratzliff's work has been pioneering the concept and real-world application of integrative and collaborative care. She is a published author in at least 35 peer-reviewed journal articles, 9 book chapters. She is the main author of a published book on integrative care, among multiple other publications. Dr. Ratzliff is renowned nationally as a leader in integrative and collaborative care and has presented to national audiences over 100 times. She has held numerous positions as a clinician, educator, researcher, and leader, and is currently the University of Washington Psychiatry Residency Program Director, overseeing the Seattle, Idaho, and Montana residency programs for the University of Washington, and is a huge favorite of all the residents. I am honored to have her today to present on a topic that is highly relevant to both now and to the future of psychiatry and psychology, titled Implementing Collaborative Care, Translation from Research to Real World. So please unmute those microphones and give a warm welcome and round of applause to Dr. Ratzliff.
Yay! Thank you for such a nice introduction. It's fun to be here. I've had an opportunity to come and speak previously, and I've talked previously more around the core model of collaborative care, but I thought it would be really fun to bring you kind of more recent work that I've been involved in around really thinking a lot more around how do we take this evidence-based model and really put it out in practice. So I'll be talking about that, and I welcome questions. So please feel free to type them into the chat box anytime, and I'm probably can integrate an answer into the conversation that we're having. I also will be happy to have a discussion at the end. And I guess I just want to invite, for those of you who may not be actually that thinking about implementing collaborative care, which many of you may not be, the ideas that I'll be talking about today around implementation, I think are really relevant for any clinical practice that you're trying to actually take from those, evidence-based papers that we all read and actually put in practice in your real world setting. So the overall structure of thinking about how do you implement as a process, I hope will be relevant to everyone. So I'll go ahead and dive in at this point. Okay. So, I do get royalties from that book. So I will disclose them, although they did not influence the content that I'm talking about today. Today I hope to talk to you a bit about common barriers and facilitators around collaborative care implementation. I'll talk about the 5 phases of implementation that we've really defined as part of the work in the AIM Center, which I'll talk a little bit more about who we are as the AIM Center. And then I'll talk a bit about sustaining practice change at the end. And I think this is an area of really growing interest in collaborative care and other processes of implementation. So I'm going to give the quick and dirty history of collaborative care. Collaborative care really started it's not that far long ago, in the 80s and 90s, when I think there was an increased recognition really that depression and other common mental health disorders really were primary care disorders, that thinking about how do we deliver care for these common mental health disorders in primary care settings really became a focus. And people started thinking about how best to do this. I think it's really interesting when we reflect, if you go back and read some of that literature, because there's very early papers like really debating whether primary care providers should even prescribe antidepressants. And now they are the most likely to actually prescribe an antidepressant. So a lot has actually happened in the last, 30, 40 years around really where we think primary, depression should be treated. In the 2000s to 2010s, there was a real shift from sort of thinking about this and thinking about co-located models to actually think about, are there systematic ways that we might deliver mental health treatment in primary care settings, really using the conceptual framework of a chronic illness model. And that's really where the collaborative care model was developed, along with lots of other people testing similar approaches. And there were basically over 80 randomized controlled trials that happened during that time, really defining that collaborative care was an effective strategy to deliver mental health treatment for depression, anxiety, across a range of populations. Also, when we see those conditions as comorbidities to other medical conditions. So really just a kind of an explosion of research, really demonstrating that organizing the way we deliver care, using that conceptual framework from chronic illness care was really an effective strategy to actually treat depression and anxiety for the most part in primary care settings. And I think, as there now is 80 randomized controlled trials, that's probably over 100 now, people began to shift to start to think about the new challenge of, okay, we know this works. How do we get it actually happening, not just in research trials or academic medical centers, but actually out there in the world where all these people with chronic mental health disorders like anxiety and depression actually are needing to get their care. And I think this is a really important societal problem because depression is the leading cause of disability worldwide. So when we think about really the public health impact of taking this evidence-based strategy and getting it out into the settings where patients really need that care, there's a ton of opportunity to not only improve the patient's life, but actually, really improve the health of our communities. So before I dive into how best to actually make this happen in the real world, I wanted to at least make sure we're all understand those core principles of what collaborative care is. So this is my summary slide of what the collaborative care model really, how it's put together for anyone that might be new to this. Collaborative care is based in primary care and really takes that primary relationship between the primary care provider and primary medical provider and the patient and adds in additional supports to be able to deliver proactive care and treatment adjustment until patients get better. So typically this includes the incorporation of a behavioral health care manager. Typical people filling this role could be a nurse, they could be a master's in social work or a master's in psychology. Often this person is really embedded in that primary care setting and has two main functions, one of which is to coordinate the care of the team. The other main role is to actually deliver evidence-based psychotherapies to patients that need those. The primary care provider continues to be the main prescriber. And then there's often a psychiatric consultant brought in, and that person's main role is to meet typically weekly with the behavioral health care manager and look at a list of patients, identify the patients that need attention, and provide both diagnostic and treatment recommendations as an indirect consultation. So this is the psychiatrist not seeing the patients directly, but discussing those cases with the behavioral health care manager, and then providing recommendations to that primary medical provider for any of the medication recommendations. This model leverages a couple of key things. You really have to have a team that's prepared, proactive, and has workflows to share all of this work together. There is really a sense that this needs to involve a very active shared decision-making perspective from the patient's perspective. And then there are several practice supports that generally have to be in place. There needs to be regular use of both screeners and outcome measures to track progress and response to treatment. So that's really measurement-based treatment to target. There's the use of a population registry. So every patient that's identified as needing this service goes on that registry and stays on it until they're better. And that allows us to also not only track who's not getting better, but who may not even be coming into care that we need to go out and find. It includes treatment protocols offering the full range of treatment for patients. So typically that includes both medications and evidence-based psychotherapies, and then regular input from a psychiatric expert through the psychiatric case review and consultation role. And as a reminder, this is super effective. This is data from the IMPACT trial, which is still the largest trial to date. There were 1,800 patients in this trial, and they really compared that model that I just described, where there was a team coordinating the care of patients, to usual care and primary care settings across 8 organizations. In that trial, what you can see is that at every single site, if the patient received collaborative care, twice as many people improved. So this really is an effective strategy to get patients better with their from their mental health conditions. And those studies and other studies beyond that have also shown that there's less depression, less physical pain, better functioning, higher quality of life, good patient and provider satisfaction with this model of care. And then in the IMPACT trial, they actually looked at healthcare spending over the next 4 years after these patients had actually received collaborative care, and found that if a patient received collaborative care, there was about $4,000 less spent on their healthcare over the next 4 years. Most of that was in avoiding physical healthcare costs, especially inpatient hospitalization. So this is an example of how we can deliver that magical triple or quadruple aim that's often the goal of healthcare improvements. There have started to be examples of people taking this model out into the real world, and this actually is a summary that comes from a paper out of the Mayo Clinic. They had some of the clinics implement collaborative care and some of those continue usual care, and this was an observational study just looking at how long did it take for patients to actually improve depending on whether their clinic had collaborative care or not. And what they found is that not only is this good at getting people better, it actually happens pretty quickly. So in the intervention, the sort of clinics that had collaborative care, patients would get better in about 3 months. That's compared to almost 2 years in those clinics that didn't have that organized approach to actually delivering mental health services. So emerging evidence that you can do this out in the real world and that it's going to have big impact on patient outcomes. So I'll kind of transition and say that's sort of a very quick overview of what the collaborative care model is. And I'll talk a bit about the AIM Center. So the AIM Center was founded by Dr. Jürgen Unitzer, who's the chair of our department. He found that after he published that IMPACT trial, people started calling him up and saying, how can I do this in my practice? I want to bring this kind of care to my patients, and realized that he really was going to need to think, he really wanted to think about this problem, and actually got funding to start the AIM Center. Over the last 17-ish years, 16 years, the center has really grown and become an independently self-sustaining center. So we, at the AIM Center, I now co-direct the AIM Center, actually have contracts with organizations and then do research around implementation of collaborative care. And so what I'll take you through is a bit about what we've learned from all of this work. So this is maps showing all of the states that we've done some kind of implementation work in, and you can see that that's most of the United States. We also have done some work internationally. We currently have a project actually going on in France. So there is, we're learning from all of these implementations. And at the very beginning, the AIM Center really, what they do is bring a team that was interested in implementing out to Washington. They would spend 2 or 3 days kind of going through a long training, and then they'd go back to their sites. And what I think that people found in the early phases of trying to do implementation that way is that there were some clinics that were wildly successful, but a lot of people went back and not much happened. And so over the last 10, 11 years, I think we've really refined how we approach implementation and have a much more defined process and phases. These tend to line up with what's sort of emerging out of dissemination and implementation science. And I'll talk you through those steps, but what I'm presenting is really a combination of literature and our experience doing a lot of this implementation work. And just to remind me, if you get interested in anything that I'm talking about, we have a lot of the resources that we've built for these various implementations we have available for free on our AIM Center website, as well as the implementation guide that I'm actually going to be showing you. We also have implementation office hours now. So every month we nationally have people be able to call in and ask questions about collaborative care implementation. And we continue to learn from this rich learning collaborative kind of environment that we have through those office hours. I also have had the opportunity to think about this at a large scale through a project I did with the American Psychiatric Association. We received money from the Centers for Medicaid and Medicare Services and Innovation to actually teach psychiatrists across the country about collaborative care. And during that project, we trained a little over 3,500 psychiatrists, which was about 10% of the APA membership at that time. And so I've also had that opportunity to learn from all of those people who went through that training. Many of them have stayed in touch. And some of what I'll be sharing with you today comes from some of those partnerships that evolved from this work as well. So what I'll talk about a little bit is how we think about implementation. And again, for anyone who may not be interested in collaborative care specifically, I think some of the things I'll be talking about are really relevant to any clinical practice change that you would be trying to make out in a real world setting. So how do you take something that you're reading about and actually put it in action? And the basic phases, I think, would be relevant, whether it's collaborative care or some other clinical implementation. There are some emerging models of dissemination and implementation that are coming out. And one of the models really is this concept that most implementation happens when there's like a core set of principles that have to be in place for you to get the kind of outcomes that you see in trials. But there also needs to be some flexibility, or what I call adaptation in the periphery, where there's actually this opportunity for those principles to be adapted to fit within the context of the clinic that you're actually trying to deliver that care. So there's always this kind of tension of what do you actually have to keep the same to be able to get, what's the secret sauce that has to be there to have the good outcomes that we see in collaborative care happen? And how do you balance that with the fact that every clinic is its kind of own environment and may need to adapt some of the ways that they think about how to deliver those services? And I'll give a couple of examples of that throughout the rest of the presentation. We have sort of 5 principles that we think are really core to collaborative care and need to be in place. These include that use of a registry and really defining a population needing treatment, that there is rigorous measurement-based treatment to target, that there is a team of people with key roles, and that we are able to deliver that full range of evidence-based treatments. And then the last principle is really important, and I'll come back to this and kind of emphasize it at the end, that you may do this slightly differently in different settings, but you have to be measuring your outcomes and probably processes of care, and be continuing to kind of tweak how you're doing that work together to get the kind of outcomes that you see in the research trials. So I'll come back to that concept a little bit more later. Okay, so What we basically have done in the AIM Center is actually define basically 5 phases of work. And this really came, again, both from evidence-based and from our experiences working with lots and lots of practices. What you'll see in this model is that we really start with what we call lay the foundation. And there is kind of a model in dissemination and implementation science called the EPIS model, and that really lines up with the exploration phase. This is really a phase around making sure there's shared understanding and agreements of what you need to actually do to deliver the change that you're trying to accomplish. There's the planning for practice change sort of part, and this is really where you actually work on the actual workflows. You're actually figuring out what kind of registry you're going to do. You're actually thinking about your long-term sustainability and billing strategies. And then the next phase is, and then you also specifically hire people for roles, and we'll actually train that team up, and I'll talk in more detail about what that might look like. And that's really the sort of preparation phase. Then you have the actual implementation phase, which is launching your care, starting to deliver services. That's where you often will, however perfect your workflow is, you'll have to kind of tweak it, make sure you're actually delivering that care. And then what we have is there's a final stage kind of called nurture your care, and this is really sustainment. How do you continue over time as changes continue to happen in that clinic, continue to deliver high quality care? So I'll talk you through in a bit more detail of how each of these phases look in collaborative care implementation. So I found some fun cartoons throughout these phases that I think really represent some of the challenges that may come up. And they're funny mostly because they're true. So, the first part is really laying the foundation. And this one says, when the whole team bought into change, something magical happened, right? So this is the idea that you really have to often bring together mental health and physical health providers. You may need to bring in your financing team to think about sustainment. You may need to bring in a clinic manager who's going to help bring in maybe medical assistants that have an important role in the workflow, right? Everyone has to have a shared understanding and ultimate goal of what all of the implementation work is supposed to accomplish. And this is really important. So this is actually data out of a implementation project that was published in 2011. This is actually a project down in Texas. And what these lines represent is really how likely is it and how quickly do half of the patients actually show an improvement. And if you remember from my previous slide, 40–50% improvement was sort of the target of what we wanted to see if you wanted to be close to what we saw out in the research literature. And what you can see here is each line represents a different organization. And there were some organizations like the bottom one that has the little crosses that actually, eventually got to 50% of their patients getting better, but it took them like half a year to figure out how to for their patients to get better. And you have other clinic systems like the one with the boxes on the top that actually could get like 70–80% of their patients better in about 4 months. So what you're really seeing here is, even though these clinic systems were really pretty similar, when they actually interviewed the clinics, it turned out that leadership buy-in and really having a clear vision was correlated with getting better outcomes. So there really is this idea that in order to build a really effective implementation, you probably need to spend some time making sure there's a shared understanding of what the work is and how you're going to get there. This has been reinforced in other trials. This is actually a table out of a paper that came out of the Mayo's out of Minnesota and something called the Diamond Project. This was a big, large-scale implementation of collaborative care. And you can see, that this paper also reinforced this concept that getting primary care provider buy-in, strong leadership support, and really a strong PCP champion were really associated with being more likely to effectively implement collaborative care. And some of the things that I've found to be helpful is to really help clinics think about what are the values that they want to have happen, and really get clear about what are the priorities, right? So of course, we'd like to do all of these things in every implementation, but I think systems actually have one that's most important to them most of the time, and making sure everybody's on the same page about that, because that might influence how you put together your workflows. So for example, in some cases, it's really about access. And in that case, you really want to make sure you set up your workflow so you can have maybe a care manager that's actually able to have a pretty decent sized caseload, right? Because you want to make sure that there's plenty of space for those patients in need. Most clinic systems do care about outcomes. You probably care about that even more if you're in an accountable care network or some kind of value-based contracting where you actually have targets that you're supposed to hit in terms of patient outcomes. So thinking about these, and this is, I find, kind of a nice organization to think about what are the values you're trying to accomplish. What we found also is that different groups are motivated in different ways when they're thinking about collaborative care. So for example, medical care providers often are really need to understand sort of what the collaborative care model is and ultimately how will it help them serve their patients. And I think that actually there's a lot of really neat opportunities to think about how you can actually build a high quality care together when you're talking to PCPs. Behavioral health providers are often not used to working in primary care settings, and this can be a really new concept. I think measurement-based care is still a relatively new concept in behavioral health, and so that can often be something that can be challenging. I think really talking to them about what value they have in this team and really bringing their expertise into a primary care setting can be incredibly rewarding, can be really helpful to engage people who might be taking on that role of the behavioral health care manager. And then, of course, psychiatric providers and how do we get psychiatrists bought in? I think this is a very different way of working. And for some people, that will be really comfortable. And for other people, that would be less comfortable. I think that if anyone is thinking about transitioning into a role as a psychiatric consultant and has had experience supervising trainees, it can feel a lot like that. You're really like building the capacity of your primary care colleagues and that behavioral health care manager indirectly. And so those are some of the things that we found to be really important or helpful when you're trying to engage psychiatrists. Okay, so, now you've got a great team, you have similar values. It's time to think about how do you actually make the changes happen in your workflow. I think Dilbert's pretty funny, and this one really reminded me of sometimes meetings I've been in where it says, this was a productive 4-hour leadership meeting. I'd like one of you to type up your notes and send an email to the entire company. And then no one took notes, right? So this is actually, I mean, a little bit of a joke, but also really important to think about is that actually, coming up with a concrete plan of how you're going to work together and literally writing it down is really important to be able to actually make the kind of changes that you need to be successful in a collaborative care implementation. And so I'll this comes from the literature. It's more than just adding team members. So in a big Washington state dissemination, and this was actually the program that I started doing collaborative care in when I graduated from residency, that was my first job, was actually working as a psychiatric consultant in this project. And what they did is it was a state funded project funded by kind of what predated Medicaid expansion, and basically the organization that was responsible for that care funded the position of a behavioral health care manager for its network of clinics, also bought time from psychiatrists like myself, and gave the clinics a registry tool and said, go do wonderful collaborative care. And what happened was that, some of the clinics figured that out, but a bunch of them actually, it was not working as well as we saw in the trials. And what you can see that here on the slide on the blue line. So again, this is what a survival curve, and essentially what it's actually showing is that if you look at that blue line, it was taking about a little over a year for half of the patients to show improvement. And that was just a lot slower than what we saw in like the Bayo study where it's like 3 months, or even in the IMPACT trial. So in this particular instance, instead of actually going out and necessarily telling each clinic, this is what you need to do, what basically the payer did in this case is say, hey, you know, part of that funding we're giving you for that behavioral health care manager, we're going to put it at risk. We're going to say you will only earn that money if you're actually meeting certain quality measures. So this was a pay for performance, basically strategy. And they said, you know, we want you to focus on a couple key processes of care. We want you to have that team between the care manager and the psychiatric consultant meet regularly. We want you to actually build a meaningful size caseload. We want you to actually engage those patients regularly, because these were the kinds of things that we thought were going to really drive better outcomes. So paid for improvements in processes of care. And what you saw is a year after that was put in place, you saw the shift in how long it took for patients to get better. Now in that whole population, what you're seeing is patients getting better in about 4 to 6 months instead of a year. So cut that time in half. And so I think this is a really good example of how when you ask clinics to focus on their workflows, give them clear targets of processes of care, you could actually see the quality of what's happening with that team improve. But it did take focusing attention, and often money helps people focus their attention. And then, you know, we are starting to also see that, you know, what are those targets? And this is a really nice example of some work that came out of that same project. And they actually looked at, you know, what are some of the things that we should be targeting as quality measures? And in this particular case, what we looked at is the patients who had had 2 visits within that first 4 weeks of being identified as needing care versus patients that didn't. So it really was a measure of early engagement. Did we get that patient back in quickly, make that second change or second assessment? And what this paper described is that, you know, if you compare those 2 groups, the patients who had that early engagement were more likely to actually achieve remission. And you can see that by that top line, getting to that 50% mark a bit sooner, and a bit more patients actually achieving better outcomes. So I think this is an emerging area of interest, is like, what are the processes of care we should be focusing on when we're doing those quality improvement efforts? And this has also been reinforced in some of the qualitative work that's been done around collaborative care implementation. What you can see here is that, you know, engaging your psychiatrist, strong care managers, workflow around handoff, making sure the care manager knows what their job is and that they actually get support to do it, and that they're on-site, accessible, really integrated into that team are probably all important things when you start thinking about what kind of workflow you need to be successful. The other big target during workflow is developing registry capacity. I think this is a really emerging and interesting area. Many people are actually building these functions into their EHRs now, but you need to have a really functional list that helps you keep track of everyone that needs care, and also that you can prioritize who needs the focused attention. So, you know, again, that care manager and that psychiatric consultant are meeting for about an hour a week. You need a quick way to sort that list into who you need to be paying attention to. Most of the time, the care managers will have about 60, 70 patients, and you need to know which are the 5 to 8 you need to actually spend that hour talking about. And so registries are really important for that. They also help us start to do that kind of proactive engagement that I already described as really an important target for quality in a collaborative care program. And this is just another example of workflow. I think one of the things that I'll focus on here is that one of the big adaptations in collaborative care is that not all of this work has to be done face-to-face, and that's been really important in the last 2 years as the pandemic came into being a big factor in our clinical service delivery. This particular example tracks a patient over time and really shows that there's frequent phone calls in between the actual clinic visits. And those are really important times to identify when a patient hasn't responded to a treatment or needs to make a change. In this particular example, you can actually see that there were several changes in treatment that happened over about an 8-week period. And in typical care, that wouldn't happen. So being able to really nimbly as a team identify the patients, make changes, have input from the psychiatric consultants at key times are all really important parts of actually building a strong workflow. Okay, so let's say you've got the perfect workflow. Now you have to train everyone in it. And it says abject terror is great for team building. So this is really kind of a joke, but it's true, right? Like you have to have that team ready to actually take on, a bunch of patients in a pretty dynamic environment of primary care. And so we find that it's really important to time this. And typically this means that the team is working on training pretty close to the time they're going to start delivering care, because there's so much important and valuable, learning that happens if you're actually applying those things you're learning about how to work together right to those first patients that you actually are seeing and taking care of together. We focus on those core collaborative care principles, but each member of the team has their own things they need to learn. And we actually did some research around this and found that what we found is that there are certain things that everybody needs to skill up around. So these tend to be the things that are common or serious in primary care. So the common diagnostic categories like major depression, anxiety, somatic symptoms, as well as the kind of concerns like suicide or violence risk assessment. And then, really everyone needs to understand about how medications are going to actually help the patient. The role shifts. So the care manager really is focused on how do they support medication management, whereas the the primary care provider is really around prescribing. And then each person has their own things that they need to work on as well. So, a lot of the primary care provider role is around how might they support the work of the care manager. So really understanding that role, as well as being able to deliver the medication. So they might need skilling up around sort of what are the classes? How do you manage common side effects? Those kinds of things. Behavioral health care manager role, again, has sort of key role in delivering evidence-based psychotherapy that may be new to them, or adapting their current skills to the primary care setting where they're going to have shorter and probably fewer sessions than they might be used to in a specialty behavioral health care setting. Care managers are really going to focus on new skills like measurement-based treatment to target, proactive engagement. Those might be new skills, as well as for most primary care providers, most care managers, they need to think about like, what is primary care if they haven't actually trained there before. And I think that there's probably more learning for the medical context for people like social workers that come into this role, and more learning of the sort of behavioral context if it's more like a nurse who's taking on this role. And then, of course, the psychiatric consultant has to learn how to deliver indirect care, how to support that team. I think this is a whole area that I'm happy to talk more about if you're interested. There's also some great training out there around this. I also think that there's an important role for learning to be a team. There's good data out there, actually from the 1950s, that shows that when you just put people together, they don't naturally become a high-performing team, that you actually need to probably do some work on that to actually get out to that level of performing. And it's important to think about, how do you build that team? How do you make sure there's shared goals, clear roles, that you know how to measure your success as a team, and that you're regularly looking at that. Then you're finally at the time when you get to launch care, and we sort of think about those first 3 to 6 months of delivering care as a really important time to see whether this program is going to become successful. This particular cartoon is kind of cute. It says, when I get asked, what will I be when I grow up? I say, how am I supposed to know I'm still on chapter 1, right? So early in your work as a team together, you're still going to be figuring out how to make this work happen. Common things that clinics need to focus on is, how do they engage patients? So often creating good patient education materials can be important, as well as celebrating early successes. And I put the video of, we do have a nice video on the AIM Center site of what this care looks like if you're kind of curious and haven't had a chance to practice as a psychiatric consultant before. I find that, it's really important that first patient that you have a positive improvement on, really making sure the whole team knows that that's happening, can really help enhance motivation to continue the hard work of practice change. And then the last phase is really this sustainability or sustainment. This is this whole, how do you nurture your care and really grow it into a productive and sustained program? And there are just now starting to be some really interesting studies about this. This particular slide comes from some work out of New York State that had a big Medicaid implementation of collaborative care. And what they looked at is after the sort of initial project of support was over, which clinics continued to deliver collaborative care. And what they found is that the clinics where they had really invested in building that capacity were much more likely to continue it. So early targets might be like really making sure you have somebody that has a full-time role as a collaborative care manager. And I think this is really interesting because a lot of clinics think, oh, we'll just dip our toe into the water, and if it goes well, we'll continue. But I think actually not building that person's sort of capacity to actually do this work most of the time may actually prevent you from ever accomplishing like a really rigorous workflow. That they built a meaningful size caseload, so a good number of patients. I personally think, and this is just anecdotal, that a lot of that has to do with you have to have enough patients to really get that workflow worked out. If you're not actually seeing a decent volume of patients, it's hard to actually make those changes. And then they got patients better. So, I mean, I think it's really important to monitor whether or not you're getting the kind of outcomes that you were trying to target and adjust the way you're delivering care if you're not. There's also a lot of new opportunities lately around sustaining collaborative care because there are new codes that came out in the 2017 and 2018. I think that this has been a really emerging area where we've seen a big explosion in really clinics trying to take on actually implementing collaborative care. We also have office hours about how to use these billing codes. They're really new. I think CMS's, these are Medicare codes, and it's really CMS trying to figure out how do we move from a fee-for-service only giving payment for seeing a patient face-to-face to really acknowledging that a lot of the work of collaborative care is really team-based and may not be face-to-face. So these codes are actually based on sort of the number of minutes that the behavioral health care manager spends on delivering care over a month. So they're a really different kind of way of thinking about how we might bill. And I think are really interesting kind of hybrid between fee for service sort of traditionally and trying to move to something that may be more aligned with sort of like an accountable care network kind of contract. And then I think the most important part about sustainability is actually that concept of continuous quality improvement. I've sort of talked about that throughout the presentation today. This is my favorite example of that I have that's sort of easy to explain. This is a clinic system that was actually part of that MHIP program. There were 2 care managers at this particular site, which was a public health clinic. What we found is they were actually getting fabulous outcomes. If you look in that red box, you could see that their average patient load for care manager 1, 50%-ish were getting better. But interestingly, care manager 2 is actually getting 70% of their patients better. Really hard population. That was incredible outcomes. And we decided to get really curious about how that was happening. What you saw here is actually that when you started to look at how these 2 care managers were delivering care, there were actually some potential targets to think about maybe mediating that kind of good outcome. So in this particular case, you can look in the first blue box and see that the average number of visits for that patient contacts was 12. But if you look at the second blue box, you can see that about half of those were using the phone. So when I talked to this care manager, what she said is, oh, it's really simple. I have a lot of no-shows. So every time I have a no-show, I pick up the phone and try to call any patients that haven't been in the last month. And I kind of problem solve with them. You know, are they getting their treatment? Can they get back in? And usually I get 1 or 2 of them on the phone when I have that no-show. And so that was really how that person was able to kind of, even within the construct of a busy practice, still be able to really be proactive, engaging their patients. And we asked, you know, basically you can then do a test of change. You can actually say, hey, care manager 1, would you be willing to try that? And then you can track outcomes over time. Could that little tweak in workflow actually make a big difference in patient outcomes? So that's really important because I think the work of implementing is actually never done. So I put this big arrow back in here because it could be that you actually, to do that kind of test of change, if you wanted to say, for example, say every time you have a no-show, can you call a couple of patients? You actually kind of need to go back through all the phases of implementation. You need to make sure there's buy-in from that care manager. Like, why is that important? You know, talk about the idea like, oh gosh, you know, we're really switching from reactive to proactive care, really get that person on board, right? You then would have to think about the workflow. How is this person going to actually remember to do that? You know, if she doesn't have a lot of no-shows, do we actually need to build time into her template, right? You actually need to think about how is this actually going to fit? You might have to build skills. You might have to say, hey, maybe the reason the care manager one isn't doing that is because they're not as comfortable delivering care over the phone, don't really know how to do that. Could they shadow care manager two and sort of see what that looks like, right? Then you're gonna have to launch it and check in the first couple. How's that going? Are you able to do it? Do you have questions about how to do it? And then you're gonna have to track outcomes over time. So one of the things I like to think of is that you're sort of never done implementing, right? Sustainment is really just continuing to monitor quality and then being willing to kind of go back through those phases and tweak things to be able to continue to do that adaptation to make this work actually happen out in your clinic. And I thought it might just be fun in the last couple minutes to share a little bit about some of the work that we're doing in this space, because I think this is an area that really is kind of the focus of the future of research around collaborative care. I am a multiple PI with Dr. Fortney and Dr. Saxon on a new trial called CHAMP. This is a trial to actually test whether collaborative care will work for co-occurring opioid use disorder and common mental health disorders like anxiety and depression. This is an RCT that's like currently happening in 24 clinics across the country. We actually have a couple of Kootenai clinics in Idaho that are participants in this trial. And this is the basic structure of the trial. We actually are looking at a couple of things. We're actually looking at how can we screen for OUD in primary care settings. We're also looking at, does this actually work? Can you actually deliver collaborative care? And lastly, we actually have a target, a research question around how do we sustain this once we've made these changes. So that Sustainment Aim is really the one that I'm taking the lead on in this team, and that we have a couple of really important questions to ask. We are wondering what are the drivers, what really helps clinics do that kind of sustainment. So we're actually going to target a couple of key areas that we think might be important and try to actually get some more data about which of these is most important. Is one of these sort of the most important? Do we need to equally focus on all of them when we're helping clinics think about how do they continue this care? So the three areas we're really looking at is, you know, how does a clinic build a way to financially sustain this work? Really thinking about that, targeting that barrier of lack of revenue. How do we actually manage staff turnover? My personal experience has been that if collaborative care is sort of owned by one person and that person leaves the system, you can see the whole thing fall apart. So thinking about how do you actually target a plan to manage that as part of sustainment. And then finally, how do you do, you know, is that quality improvement? You know, I just pitched to you that I think that's a really important part of sustainment, but how does it play a role? That monitoring specific quality aims and then targeting them afterwards. And we're calling that fidelity drift. Do you actually target that, and how much of a role does that play in actually sustainability? So we're about a year out from hitting this part of the trial, so I don't have any answers for you yet, but maybe in the future I'll be able to come back and talk to you a little bit more about CHAMP. I would say the first thing that we've done is actually done a lot of work on screening for opioid use disorder in primary care, and we have already learned a lot. although the first thing that we learned is what not to do, which often happens in trials. So I think there's a lot of really rich opportunities around implementation as we continue to do trials. I think there'll be a lot more trials like this where we have both an effectiveness trial, like does this even work, but also really looking pragmatically on like how do we make this work? You know, what are the implementation and sustainability questions that we should be asking as we are testing new models so that we make sure that they can get from those research trials out into the real world. So really exciting stuff. Just wanted to give you a little teaser for the future, some really interesting work that we're engaged in now around new ways of delivering collaborative care and new targets to try to understand sustainability. And I'll stop there. I just want to always give a shout out to my AIM Center team. I shared a lot of work that many of them led, or resources that my team helped develop. So always want to give appreciation to that. I also put our AIM Center link on here and then my email address. I'm happy to answer questions. I'm also happy to just open it up to questions now. And I don't think I've seen any in the chat, just information about CME. Any questions?
Hi, Steve Brown here. I'll do a comment.
Yeah.
It's beautiful research. It's fantastic because you're doing it both on what are some clinical interventions that help, and then also doing the systemic things of how is it, what's getting in the way of implementation. So that's what's so one of the things that's so impressive with the research. So it's more of a comment than a question.
Yeah, I mean, I think it's such an interesting, such an important comment, though, because I do think that there's an increasing focus in the literature on that we need to be doing both, right? There's like in the literature, people have looked at this, like how long does it take from when something is discovered or proven to be evidence-based for us to start doing it regularly out in practice? And typically that gap is on average, sort of the number out in the literature is 17 years. And if you think about it, we've actually seen some really interesting things happen in the last couple of years where we've squished that way down around the pandemic, right? I mean, there's been some really interesting opportunities to see like actually rapid transition of things that we're learning being put into clinical practice at a large scale pretty quickly. And I personally am really intrigued by that because, I mean, clearly this was it's a crisis, this is an emergency, but what are we doing differently that's allowing us to do that so nimbly? And can we learn from that, right? Because it seems like there's so many areas that we still have things that we need to improve on. And we need to move it faster. 17 years is just way too long. So I think that this area of implementation science, really saying up front that not only do you need to try to innovate new things, but make sure there are things that people can actually do in the real world, I think is an increasing focus in the research world and a really exciting one. So thanks for that comment. I too share your excitement about it.
You may have addressed this. I had to step away to use the restroom for a portion, but I had a question about for the clinics that are having trouble kind of conceptualizing how this can be helpful. And I imagine, or that people might say, especially the providers, now I'm going to have to address all these psychiatric concerns in my visit instead of being able to just refer to the psychiatrist. Do you have any data or something that you might say to those clinics to say, how much longer it might actually take to address these issues in the primary care clinic setting?
Yeah, I think it's a really important question because I think sometimes if people are already really comfortable with their current workflow, you have to almost de-implement that before you can start to implement something new. And if it feels like something's being taken away, and maybe in this case, it's I could just say, okay, this patient's gone from my caseload. I don't have to do this thing. Some people call it the eject button. I don't love that analogy, but the concept that, maybe you can actually just hand that off to someone else, that can be a really like, I think for many people that feels really good. I think the two things that have been, so it's hard to like change to something where you like still hold on to that patient, and that is actually hard. So I think there are two things that I found to be helpful in the early conversations, and then something later. So the two things I found to be helpful in the early conversation is actually really looking at their data and understanding how many of the people actually made it to whatever they actually said, because the reality is most patients don't actually go. And so what you get is a patient that, yeah, you feel better because you've done what I did what I was supposed to do. But most people, I find most primary care providers really care deeply about their patients. And when they realize they're not actually getting the care they need, that motivates them to maybe try something different. So that can be a really helpful strategy, is actually look at the data on who isn't actually making it to that other level of care. Because there's some literature out there, probably about half of the people don't even make it to the referral that people have given them. And probably when people do go, they only stick for a little while, because it's, for various reasons, cost and inconvenience and all of that stuff. So that's one thing. The other one is capacity. So I think sometimes, let's say you have a co-located psychiatrist in your practice that's there a day a week. I mean, they're at most going to probably serve like 50, 60 patients over a year. If you have 10 PCPs in the practice, that means only 5 of them do you get to send to that psychiatrist. And people don't think about it. They think about only theirs, right? And so if you can somehow represent the true capacity at those levels of care of sort of referral, especially if it's kind of more of a closed system, I think that really helps people understand, like, oh gosh, I have more than 5 patients that are going to need help. I need to build another level of capacity here. And I think also, if there still is going to be that pathway, but it is really practically very few patients, it helps people start to triage, like, who do I think I could actually take care of here, and who really needs those 5 spots, right? And so I think any ways that an organization can kind of actually define their capacity at those different levels can be really helpful as you're having that engagement conversation about why this needs to happen. And then later, I think it's really important to celebrate successes or show them the kind of outcomes that their patients get. Because I think very early on, it can feel like more work. But as they start to work with that care manager and realize, oh, this is really going to be a partner, they're really going to have my back, and that the psychiatric consultant, if they call them for help, will answer the phone and actually support them, I think people over time are like, no, this is better. Like, I have a lot more support, even if I have a bit more responsibility to actually serve my patients. So I think it's important to like feedback data, like, look at how many of your patients are getting better, have success stories and have attestations from other PCPs around why this is a meaningful way to do that. That can be really helpful to like solidify that change, or maybe engage those people who are, there's always early adopters in a practice and people who are a little slower to adopt things that are new. So if those early adopters can sell this to their peers, that's often more effective than if I come in as a psychiatrist and they're like, yeah, you don't know anything about my world. I mean, I actually have worked in primary care most of my time, but I'm not a primary care provider, right? So I do think that there's something really powerful if it can be a peer that says, no, this is the thing we got to do right by our patients. So those are a couple of ideas. Does that help?
Yeah, thank you.
Well, I see it's just about noon, or my time, so it must be 1 yours. So I'm happy to answer additional questions, or if you're actually implementing and want some support, come to our implementation office hours. The AIM Center